Inspire FM 105.1 FM, and it's wonderful to have you back. So much has been going on in the world over the last couple of weeks, and since my last show we had a lot of positive feedback from my last show, so I'm always eager to bring across wonderful guests who are experts in their field so that I can share some knowledge with you about different topics. So absolute privilege to be here once again. Your very own Dr Shabina. You know that I'm a local GP within the city of Peterborough in a very, very busy practice, but I love what I do, and part of doing what I do brings me here to host these weekly shows, health shows to you. So wonderful to have you in. So as usual, once I introduce who our new guest is, it would be wonderful if you could participate by texting and WhatsApping on 07745278978, or you could participate in the conversation on 01733 602 133. And you can follow us on the Facebook page, which is the live Facebook video link. We are also live on YouTube Live. We are also live on Twitter Live. See, via all these channels, we try to communicate with you. So do take advantage of looking at us on these networks as well, because we do want to bring you the very best show. In fact, I walked into the studio today. It was so funny. I was telling our studio station manager, Brother Qasim, that I sat down on the chair and the table was coming up to my neck, and I thought, my goodness, who was this tall person that sat on? And when I put the headphones on as well, I thought, this person has a very big head. And I realized that the only person I could think of who did the show before me was our very own Uncle Ansar Ali. So this is just to let you know, Uncle Ansar, if you're listening in, that I did have to adjust the seat and the headphones so that they would accommodate me. But without further ado, let me introduce you to my next guest for this week. A very esteemed guest, very privileged guest, an expert in his field. He is Mr. Shabi Ahmed, who is a consultant urological surgeon at the Sandwell and West Birmingham NHS Trust. He is MBBS, MRCS, FRCS, FEBU. He's also president of the Dow Medical College of Northern Europe alumni group from 2018 to 2020. And he's also been the past general secretary of the Patients Welfare Association, which is a charitable organisation in Pakistan, Karachi. He's an advisor to the Indus Hospital's healthcare network in Pakistan, and also to Sindh Institute of Urology and Transplantation, of which has been pioneered by Dr. Pradeep Ul Hassan Rizvi, and is also a member of the Midlands Doctors Association. Mr. Shabi Ahmed, Assalamu alaikum. He's also my classmate as well. Mr. Shabi Ahmed, Assalamu alaikum.
It's absolute honor to be with you.
It's absolutely wonderful to have you. Thank you very much for taking the time out to talk to us today and to help spread the knowledge and realization, as well as enriching us with common ailments or problems, I think, in your field of speciality, which is urology.
That's correct. I mean, there is a lot of urological problems. There are things which are myths. People are not very well aware of it. It's a very personal thing involving the urogenital tract, and most people are not very keen to engage and not very keen to tell what exactly is their personal problems, be it ladies or gents.
Sure.
And this is really a talk to discuss the various things which might be troubling somebody, but they're not very keen in coming forward to talk about it.
Sure.
And it's just to reassure them and give them the hints that what are the telltale signs or red flag signs that they need to be aware of in order to get things investigated in time and get proper treatment. Mind you, most of these urological problems are very, very treatable.
Yes.
And if found in time, people will benefit a lot, and that will cause much better impact on their overall health and well-being.
That's true. And I think one of the reasons why, Mr. Ahmed, we do bring such topics across, I wouldn't call them taboo, but I do feel that there is rather, especially within the community, within the Muslim Asian community, for maybe cultural reasons, that people don't like to divulge such symptoms because they feel an element of embarrassment. And one of the purposes of these shows, which you've given your kind time to, is to help dissipate that so that people can come forward and actually talk about problems that are taking place. And there's nothing shameful, really, in doing so, going to their doctor or their GP, because we see people as patients, really, don't we?
That's very true. I mean, people, men or women, naturally in our culture and with our religious beliefs and our needs, people like to be clean, people like to be wearing clean clothes, not getting disturbed with their urinary problems. And if there is something hampering that or causing problems with that, it is very uncomfortable for the individual.
Yes.
And therefore, be it ladies or gents, again, they would want to have some sort of awareness and get those things sorted out as soon as possible. I mean, in our culture, for example, ladies, what I've seen in my practice is people with problems for years and years only coming in for treatment or to the hospital at a very far stage. And if they would have come in earlier on, it would have made matters much easier to manage. And again, the same goes for men as well. So yes, taboo might not be the most appropriate terminology for it, but yes, there are restrictions which we tend to impose on.
I think it would be important really to talk about the structure of the urinary tract in men, because you also have the prostate that's involved, and you don't have a prostate gland in females.
Correct. I mean, as a urologist, if I talk about matters very simply, the urogenital tract is divided into the upper tract, which is the kidneys and the ureter tubes, and the lower tract, which is the bladder and the prostate in men. And naturally, in females, it's there isn't any prostate, and it's just the bladder and the upper tracts. So, excuse me.
No worries.
So being a urologist, it's our job to look after the whole urogenital tract.
Yeah.
Things which are very common and that need to be referred and investigated is blood in the urine, or hematuria as we call it in medical terms.
Okay.
Now, hematuria can happen anywhere, or any organ can produce it, be it the kidneys, down the ureter tubes, the bladder, or prostate in men.
Okay.
And that is something that if somebody has seen visible hematuria, visible blood in the urine, be it whatever age they are, that needs to be acutely flagged up, and patient needs to be referred.
Okay.
Similarly, in our population, in the Asian population, the kidney stone disease is extremely prevalent.
Yeah.
And whether genetic factors or whether it is environmental factors, we find that stone disease is extremely rampant.
Right.
So if somebody is having recurrent infections or back pain which is unexplained, and even blood in the urine, again, that needs to be investigated. Because mind you, if there is a small stone, even less than 5 millimeters, and if that is obstructing the kidney, if left unchecked, in about 2 to 3 weeks time, that kidney will lose its function.
Right, okay, so that's how important it is. And Mr. Ahmed, with regards to urinary symptoms and blood in urine that you have just described, are there any particular symptoms that one has to take note of? Now, blood in urine can both be visible and non-visible. That is, when you go to a doctor and they do something known as a dipstick test of the urine. Is it also pertinent to pay attention to what we call microscopic or invisible hematuria, which is blood in the urine as well?
Invisible hematuria or dipstick hematuria, or in medical terms as we call it as non-visible hematuria, if it is persistent on 3 different days without any other precipitating factors of infection like burning sensation, discolored urine, foul smelly urine,
Yeah.
painful bladder, then that is something again that needs to be investigated.
Hmm.
And therefore, the primary care physicians like yourselves refer these patients to us for similar sort of investigations which we do for visible hematuria. All, mind you, even in 10% cases in which we find bladder cancers or bladder tumors, there is no visible hematuria. It is non-visible hematuria which picks up these things. So, and 1 out of 10 person with bladder cancer will not have had any blood in the urine or any visible blood. It
Right.
will just be found on non-visible hematuria.
Right, okay. And from a point of view with regards to a patient, for example, a lot of people say that having sort of painful urine, and I've been asked this question before, that when somebody passes urine in a painful manner, as opposed to somebody having, say, painless blood in the urine, people think that having pain is actually a more reassuring sign as opposed to not having pain. What are your thoughts on that?
It it uh, it might be a red herring to have infection superimposed on something more sinister underlying. So I would advise people not to disregard this finding. And yes, it might well be that they have a urinary tract infection which was causing the painful urination, but
Sure,
that simply does not mean that there might not be something hidden which might be more sinister,
sure.
which needs investigation, be it a bladder lesion, be it a kidney lesion, or something other which might require treatment. Big stones in the bladder, if left untreated, will cause or will risk the formation of bladder cancer.
Right,
So
okay.
again, that is something which needs to people need to be aware of.
Yes, absolutely. And I must say that from my own learning perspective, being in primary care, I've always, everybody has sort of their fortes and subjects that they are rather more tuned into. And obviously, women's health is one of my fortes. But the urological side of things, I do tend to ask for a lot more advice and guidance as compared to other subjects. So I'm taking on quite a lot of this on board as well. And I think that it's really important that we are talking about this. Now, coming to the prostate gland, would it be possible, Mr. Ahmed, that you could explain to our listeners the function of the prostate gland and what it does?
So prostate gland is a small gland which would weigh anything between 15 to 20 or 25 grams in an healthy adult male.
Mm-hmm.
It's a physiological gland. It is supposed to secrete various hormones and secretions which are responsible for various sexual functions in men.
Right.
And with time and age, especially after the age of 60,
Mm-hmm.
prostate gland starts to enlarge in size
Okay.
and can cause obstructive symptoms in which the urine flow out of the bladder is impeded or is blocked at the level of the bladder neck by an enlarged prostate.
Right.
Now, prostate cancer per se is the most common cancer or any urological cancer in men.
Mm-hmm.
The amount of people who die of prostate cancer is pretty much equal to the people who die with lung cancer. So it could very well be classified as the biggest killer in men
Right.
in any population. Yes, the Afro-Caribbean population has got a much higher
Oh,
risk
yeah.
of prostate cancer. The Asian population per se has got lower risk of prostate cancer. Having said that, it is by no means a guarantee that one will not develop prostate cancer.
Sure.
So if any men after the age of 55
Mm-hmm.
is starting to have increased difficulty in passing water,
Yep.
waking up too often at night, a slow urine flow, urinary tract infections, and even blood in the urine,
Okay.
they need to refer themselves to the primary care. They need to have a rectal examination.
Uh-huh.
They need to have a PSA blood test, which is called a prostate specific antigen,
Yeah.
which is specific to prostate, but it's not specific to prostate cancer.
Okay.
So I would like to clarify this, that if somebody has got a raised serum PSA, it definitely does not mean that they have got prostate cancer,
Okay.
because rise in serum PSA could be due to many reasons.
Sure.
But only it means that people need to be referred, investigated, and treated appropriately, and rule out any prostate cancer or any risk of prostate cancer.
Okay, that's wonderful. Now, because we are talking on this subject about the prostate in terms of prostate cancer as well, I think it would be important to make our listeners aware, Mr. Ahmed, of specifically what symptoms to look out for. You did mention frequency of urine or trouble in passing urine. Would it be okay for the purpose of our listeners to point out what type of problems within urine one should expect or look out for to instigate a visit to their GP, please?
So as I said, increased frequency of micturition, which has change in character of late.
Okay.
Nocturia means waking up at night to go to the toilet.
Okay.
Any difficulty in passing water, where the flow of urine becoming slower. And importantly, the more sinister signs might be unexplained pain in the bones, or weight loss, or just feeling unwell. Now, having said that, with all these symptoms, a big proportion of prostate cancers are silent disease, especially the low grade and intermediate grade ones. And for that purpose, any person who has got any risk factors involved, they are smokers, any previous family history of prostate cancer, and they are 55 plus, it is always advisable to get checked with a rectal examination and a serum PSA from their own doctors, and then get referred appropriately.
Okay, so that's very pertinent actually, because I do get a lot of people who have said, oh, you know, for years I've been getting up in the middle of the night, and I've got up at least 2 or 3 times in the night, and it's only that I've spoken to somebody that now I've been told that I need to see a doctor about it. So obviously it has been left for a while. So if for all of you listeners that are listening, and this is Dr Shabina Sidkiyin with Mr. Shabi Ahmed, who's a consultant urologist at Sandwell and West Birmingham NHS Trust, who's joined us kindly today, and we're speaking about urological problems within men at the moment. And if you'd like to talk to us or ask us a question, please call us on 07745 278978, that is send a WhatsApp message, or you can join us on the studio telephone by having a conversation by dialing in on the Peterborough code 01733 602 133. And what Mr. Ahmed has said is that to look out for specific symptoms, although some of these may be silent as well, but have a look in any trouble in the flow of your urine, so difficulty initiating your urine and waking up at night time quite frequently, any weight loss, feeling unwell. Obviously you're at risk if you're a smoker, and I always do stress on health promotion advice in my shows. 55 plus, and if you do, a more sinister sign is obviously pain in the bones, etc. So these are some very important things to consider and to think about as well, and to visit your GP so that an examination can take place. And Mr. Ahmed has said that one of the examinations that takes place involves examination of a prostate gland, and how you examine the prostate gland is via a digital rectal examination. Okay, so you have to be prepared about that. And again, I think both of us reiterate that there is absolutely no shame in having these examinations done, because doctors see you as patients. They either see you as male or female. So although you can express a preference. Now, I have a question here from a Dr. Masroor Khalid Chima. I have 2 questions. If the PSA is normal, but the prostate size has increased from 45 grams to 65 grams in 2 years with not much change in symptoms, is this of any concern?
See, the most important thing is has that been ascertained that the prostate size has increased from 45 to 65. If it is on the base of a rectal ultrasound, which is the most sensitive test for this, then that is clinically relevant.
Okay.
If it is just on the basis of a rectal examination, then things can vary according to the experience of the person who's doing the examination.
Okay.
Therefore, in a case when the nature of the prostate appears benign and the
Mm-hmm.
patient is not acutely symptomatic with a normal PSA, then we would just simply observe them. Having said that, with a normal PSA, if the prostate appears abnormal in examination,
Mm-hmm.
then they should be investigated for prostate cancer, because we do find that about 3% of prostate cancers, the PSAs are normal and people still have got prostate cancer disease.
Okay. Now, Mr.
So,
Masroor Khalid
so
Chima's, sorry.
the nature of examination is important in this particular case.
Okay, so Mr. Masroor Khalid Chima has gone on to say that the question is relevant with regards to assessing the size, number one, with ultrasound, and the man is 75 years of age with a family history of prostate cancer. Then what would be your outlook? They haven't had much change in symptoms, but the size is increased on ultrasound from 45 grams to 65 grams in 2 years, and the PSA is normal. What would be your outlook on such a patient?
Well, according to the NICE guidelines, we now tend to do a multi-parametric MRI scan on prostate disease.
Okay.
So, in the context that the gland has increased in size quite considerably over the years, I would like to consider giving an MRI scan to this patient.
Sure.
And it is done in various phases. And if there are any abnormal areas of uptake, then targeted biopsies might be required in this particular case.
Okay. So again, it's sort of treading with appropriate investigation thereafter, going for an MRI scan so that you can ascertain whether there are any abnormal areas of uptake within the prostate gland. I hope that has answered your question, Dr. Masroor Khalid Chima. Thank you very much for joining in. We also have some really encouraging comments here. We have a Dr. Khurram Abdullah, very nice program, and Dr. Mohammed Pervez, wonderful effort. We've got quite a few medic friends, which is wonderful to see. We have a Mr. Faz Ali who's joined us, Sabina Usher who's joined us, Azhar Chaudhry who's joined us. Lots of them are medic colleagues. It's wonderful to have you on the show. Brother Shakil Puri has joined us. So thank you very much for all joining us today and giving us this support. So this is about... we're talking about prostate cancer. Now, we have at least 3 minutes before we go for the break. Now, somebody has been diagnosed with a prostate cancer, Mr. Ahmed. They've referred to your clinic. What are your next steps with this patient, please?
The prostate cancer is a very wide spectrum of disease. It goes from, it's divided into 3 categories, low, intermediate, and high risk categories.
Okay.
80% of the prostate disease is not life-threatening. It's not life-limiting.
Yeah.
And it is only a select group of the high-risk disease which has the potential to cause life-limiting influences.
Right.
Prostate cancer by far is the only cancer in the whole spectrum of diseases in the human body which has got the most forms of treatment available.
Wow. Okay.
It is highly sensitive, it is highly hormone sensitive, and mind you, if it is a low risk, which is a low volume disease, you must, as a GP, I'm sure you've heard about the Gleason score.
Of course, yes.
So even mere observation or active surveillance, as the terminology we use, is adequate enough for treatment. That is no treatment, and mere surveillance which in a disease which will not be of any life-threatening nature for future reference.
Okay.
On the spectrum, if for intermediate risk disease for younger person who's got a life expectancy of 20 years plus, we have options of radical surgery, in which we are doing it robotically these days. Of 7-8 years ago, when I was training, we used to do that as an open procedure, in which there used to be a hospital stay of about a week, blood loss of nearly a liter.
Okay.
Now we are doing that robotically, in which the patient goes home the next day.
Brilliant.
Blood loss is hardly 200 or even less, and the functional capacity and functional risk factors are much better, much less incontinence, and
So,
much.
yeah, so sorry to bother you. We are approaching a break. We will come back and we have another question that's come up by Dr. Azhar Chaudhry. Join us after the break.
Okay, thank you.
Stay tuned to Salaam Radio after this short ad break.
In just 2 weeks, the death toll in eastern Ghouta has reached over 1,000. Violence and airstrikes continue to devastate life, leaving people without the basics they need to survive. These are desperate times for the people of Syria. Join Human Appeal this Saturday the 24th from 4 p.m. for a live appeal in aid of the people of Ghouta on Salaam Radio 106.2 FM or online at salamradio.co.uk.
Have you visited Amar Food Store yet? Now open at Lincoln Road Triangle, 613B Lincoln Road, Peterborough. Pay us a visit and take advantage of our special offers and great range of products on groceries, vegetables, fruits and halal meat. All your favourite brands under one roof. We take payment by card, have free customer parking and offer a free local delivery service. Also available, Payzone for bill payments and money transfer services to Pakistan. Amar Food Store and Halal Meat. Now open at Lincoln Road Triangle. Call us on 01733 68 73 74. High in quality, low in prices.
Third world and developing countries are home to some of the most vulnerable children on the planet. Malnutrition, severe lack of medical aid and access to clean water are just some of the horrific challenges faced by orphans across Africa and Asia. Children of Adam, a Peterborough charity, need your help to bring aid to these orphans for just £25 a month. To sponsor an orphan or assist with other projects, please call 0300 321 0032 or visit www.childrenofadam.net.
Do you own a restaurant or takeaway? Cater Fair is an expert supplier of new and used commercial catering equipment. Visit caterfair.co.uk for quality equipment on sale at the lowest prices, or call us on 01733 310 115 or visit us at 11 Royce Road, Fengate, Peterborough.
Need a great place to chill out? Look no further than The Lounge for quality food and drinks at a great price. Try our varied menu: pasta, seafood, burgers, grills, salad, soup, rice and sides. Also hot and cold drinks, milkshakes and mocktails. Leave room for our exquisite desserts. The Lounge, 417 Lincoln Road, Peterborough. Call 01733 709 306 to order for delivery. The Lounge, friendly service with a great atmosphere.
Gems and jewels. Wise sayings, interesting events, and moral lessons from Islamic history. Choosing a husband.
A man asked Hassan ibn Ali, radiyallahu anhu, I have a daughter, and people have proposed to her. So to whom should I marry her? He said, marry her to one who fears Allah. For if he loves her, he will honor her. And if he hates her, he will not wrong her.
You're listening to Peterborough's community radio, Salaam Radio, 106.2 FM.
Assalamu alaikum and welcome back. Welcome back to this really wonderful show, which has really got me intrigued. We've developed a lot of interest in this show, which is absolutely wonderful. This is the way we like to do it. Very own Dr Shabina Sadkiyum on Salaam Radio 106.2 FM and of course in Luton, Inspire FM 105.1. text us on WhatsApp on 07745278978 or on the studio telephone number 01733 602 133. Now we have Mr. Shabi Ahmed, who is a consultant urologist of the Sandwell and West Birmingham NHS Trust. And before the break, we were just speaking about and answering some questions regarding prostate cancer and how Mr. Ahmed was explaining as to what the treatment takes place thereafter, after diagnosis. And actually we've got a couple of questions again, Mr. Ahmed. We have from Dr. Azhar Chaudhry. Any update on using PSA as a screening test, please?
Unfortunately, we haven't established a screening protocol for prostate cancer in this country or world over, for that matter.
Right.
So again, at this moment of time, PSA is being sporadically used in high-risk groups or in symptomatic groups or in individuals who are concerned about PSA. The risk is that if we start screening the silent population with PSAs, the risk for prostate cancer is so much that you would need 10 times the number of urologists what are being available at this moment of time.
Right.
And the system per se will not be able to cope up with so much of prostate disease. But mind you, as I said before the break, most of these diseases, more than 60%, is just low risk, low volume disease, which by far does not require any treatment.
Right.
And therefore, even if you do investigate, which will cause a huge volume of resources in an already stretched NHS, and in the end, if you don't do anything, then one would question, why did you waste so much resources for a disease which in the first place never required any treatment or would not have limited the lifespan of the patient. So that's an argument that really nothing needs to be done about these people.
Okay, I see. And just before we move on there are some questions pertinent to women's urinary symptoms as well. I would just like our listeners to know, please, Mr. Ahmed, if you could tell them the precautions that they have to take before having the PSA blood test, because that's also important as well, isn't it?
I'm very glad you asked this question. Especially for men who have had recent symptoms of a urinary tract infections. And mind you, it used to be a myth that men don't get urinary tract infections. Yes, they very much do that. Maybe not as commonly as compared to the ladies, but yes, it does happen very frequently. So if somebody has had issues with burning micturition or any foul-smelling urine or discolored urine, difficulty in micturition and passing urine, which has improved with the use of antibiotics, then these are the telltale signs of a possible urinary tract infection. And therefore, once the infection has settled, they should not immediately have a PSA. They should wait for at least 6 weeks before a PSA blood test should be undertaken.
Okay.
As otherwise it will give a false negative reading for false positive reading, and unnecessary investigations would be initiated. Patient will have mental anguish in the fear that they've got prostate cancer and have to undergo that trauma for the next 6 weeks till they have a repeat blood test, which in most cases will show that the PSA has come back normal.
Right.
So, and I think this is something which I would request you as a primary care physician to be careful in whom you request a PSA.
Sure.
Similarly, if somebody has had any genital trauma or prostatic trauma, any instrumentation like a catheter, any sexual intercourse, which will all give rise to the PSA and might not give a more representative result.
Okay. I think that makes that very straightforward, actually. So, listeners, if you have been listening, Mr. Ahmed has given us precautions on when is an appropriate time and in which conditions actually the PSA can be falsely elevated. So, if you've got any questions surrounding that, please do call in. I do have a question. This is from, again, Mr. Masroor Khalichima. He is a consultant gynecologist, actually, and he's asked a really important question. I think it's very fortunate that we have a urologist and a gynecologist here, because this is something that could help us as well. And his question is, it's about the recommendations of having a catheter after spinal anesthesia following a C-section. And his question is that we normally keep a catheter for 6 hours, but there is new evidence regarding enhanced recovery advocating the removal of a catheter after surgery and hence early mobilization. What are your thoughts or advice for him as an obstetrician, actually? Does a catheter need to be removed earlier to an early mobilization, or does it need to be kept in for 6 hours?
I would say that it is principally based on a case-to-case basis.
Sure.
After the spinal anesthesia or an epidural, which happens for various obstetric procedures, it at the end of the day, it is on the onus is on the patient how much they are comfortable, and when they would start to ambulate and start mobilizing.
Sure.
And the sooner they are ready to mobilize, the catheter can come out. And I mean, it's difficult to put a time frame to it. Okay. Surely, if somebody is catheterized and the catheter has been removed and the patient is still in considerable discomfort post-operatively, then that will only cause more misery and more discomfort for the patient. So it has to be clinically evaluated before you take the catheter out, rather than going by any time-related protocol.
Okay. In fact, it might be good to actually do a study on something like that, because I'm sure that the findings would be quite significant and helpful in early mobilization as well, with regards to such females that undergo C-section. Yes. So, having said all of that, I think it's appropriate now to move on to female urological problems as well. And we know that females suffer from urinary tract infections far more than their male counterparts. And with regards to female urinary tract symptoms, what is it that you most commonly see within your daily practice, Mr. Ahmed?
I'm really glad you asked this question, especially for our lady listeners and from our community.
Sure.
As I've seen so many times, and in my practice, in which covers mostly an Asian-dominated community in Birmingham.
Yeah.
There are lots and lots of social stigmas and myths involved with urinary problems. Now, as per the data we have, every female, be it whatever age, will have at least 2 to 3 water infection in their life. So the risk of water infection in a female population is about 30% to 40%, and out of that, 10% will have significant symptomatic infection requiring treatment.
Okay.
And out of that proportion, at least 3% will have significant enough infection that can cause hospital admission, and in rare cases or in extreme cases can even be life-threatening.
Right, okay.
So if any ladies who are having recurrent problems with dysuric symptoms, passing blood in the urine, painful hematuria as we discussed earlier, increased frequency of micturition, poor flow, incomplete bladder emptying, pervaginal discharges associated with it, and as well as lower urinary tract symptoms of daytime frequency, urgency, they really need to be investigated and helped with.
Okay.
Similarly, incontinence is a major problem.
Yes.
Now, again, 5 to 10% of a healthy female population has got some element of an overactive bladder, or a detrusor overactivity as we call it in urological terms.
Sure.
And that can be anything which can be managed at home, managed in a conservative manner, to the other extreme in which the patient is extremely incontinent.
Okay.
People come to me with years and years of suffering, and at that time they are completely wet. They are using 4 to 6 big pads per day.
Oh dear.
And if you ask them how long has this been going on, some may even tell you that this has been going on for 10 years or even more.
Oh dear. Okay,
Which
very sad, isn't it?
distressing. Because had these people come up earlier and started or have initiated their treatment, they could have settled down in a few years' time.
Okay, okay. So, what I'd like to ask is, in terms of urinary tract problems with ladies who have incontinence, the first take-home message is that if you find that you're having to find a toilet to go to as soon as possible because you're scared that you may soil yourself, that's one aspect that you need to go and see your GP about. Obviously,
unexplained urinary urgency, which is persisting for at least 3 months in the absence of any dysuria or any other symptoms of UTI. And if the symptoms are persisting and getting worse, and if there is any element of leakages or urge-related incontinence, that is something one should not take it very easily, or should really get investigated and managed.
Okay.
Similarly, after childbirth, after normal deliveries or even C-sections, there is a big risk and big proportion of people who have got stress-related incontinence. And again, this is a big taboo in our population, that young ladies are very reluctant to come forward who are having this sort of problems.
Okay.
So the message is that if they are having problems with stress-related incontinence, it is a very simple day case surgery procedure they can have, which can deal with stress incontinence, and they can be dry with a good quality of life for the rest of their lives. So please come forward. If you are struggling, if you have these symptoms, we are there to help you. We are there to guide you, and don't suffer in silence. Please come forward and we will look after you.
That's a wonderful message from Mr. Shabi Ahmed, who has said to all females and all women alike that if you are suffering from any urinary symptoms whereby you're having problems sort of going to the toilet or incontinence, please don't feel shy or embarrassed of approaching a doctor. You will be looked after. And again, like we say, that it's part of our religion to be clean and want to feel clean as well. So you will definitely be assisted with that. And before I speak about various treatments regarding that, Mr. Ahmed, I have another question here from Harriet Marshall, who is asking, and I've tried to look at this question, try to understand it, and I hope that you'll understand it. If prostate-specific antibodies are used to identify cells in women, do women have similar cells to prostate cells? Or are there other types of cells detected by the prostate-specific antibodies? Do you sort of understand the gist of that question?
Eva, one thing I would clear that it would be prostate-specific antigen. It's not possible.
Okay.
Prostate-specific antibodies.
Okay.
As I said earlier in the program, this hormone, well, this particular agent is secreted solely by the prostate.
Okay.
And naturally, as the term goes, there is no equivalent or similar thing which happens in a female.
Right.
So therefore, prostate-specific antigen is a very male-specific parameter.
Okay.
And per se does not affect the ladies. Yes, there are other lubricant glands in the lower genital areas in females, which are responsible for formation and secretion of various other lubricating secretions, but the function of PSA is not similar to that.
Okay. Well, I hope that that's answered your question, Harriet, and thank you very much for that question. Now, going on to treatments for incontinence in women, Mr. Ahmed, could you give us a brief overview of what the stepwise approach to incontinence in women would be, please?
The first step is recognition. If somebody is recognizing that they have got abnormal symptoms which have persisted for a period of time, then they come for help. The first thing is trying to moderate things in a conservative manner. by moderation of their fluid intake, by cutting down of various stimulants and irritants like caffeine containing drinks, tea, coffee, if some or the fizzy drinks, they have got a lot of volume of caffeine. They can irritate your bladder and cause these symptoms. Then weight reduction, that helps a lot in terms of management of symptoms. And once you the pelvic floor exercises, they are very effective, especially for stress related incontinence. And mind you, if there is a need of it, it should better be taught by a physiotherapist, in which the exercises are done more appropriately and more correctly and are more effective. Once you exhaust all these means of conservative methods, then you come on the lines of managing things pharmacologically. So there are various modalities of treatment and medications available for overactive bladder, for urge incontinence. There might be some available for stress incontinence as well. And once there is a whole spectrum of agents, as I said, once you've used them and things have not moved on, you are still symptomatic, then there are more intrusive sort of investigations or more thorough investigations for bladder pressure management and things that can be done with a view to give therapy inside the bladder. Like you might have heard about botulinum toxin, which is used a lot in the cosmetic industry. But then again, it is used for stress for urge incontinence in males and females. And the spectrum goes on. There is neurostimulation, neuromodulation, that is the recent advance in the management of urge incontinence. So the earlier you come, the more early we start treating, there is more hope that we will get you to a complete cure. So come early, get investigated, get treated.
That's brilliant. And I think that gives a very, very thorough overview as to what can be done, stepwise approach. And I'm going to take you back, if I may, Mr. Ahmed, to the beginning with regards to pelvic floor exercises. I cannot tell you the number of women that I see who will come back to me within a month or within a week to say, that doesn't work, I do these pelvic floor exercises, it's still not the same. And when I go into a bit more detail with how frequently they've done the exercises, it really doesn't seem as if they have done them with the frequency that would bring about giving results. And for the purpose of our listeners, would it be okay if you could explain to them how long actually do these pelvic floor exercises need to be done before they see results?
These exercises, if done correctly, and that is why I was insisting on the need for it to be taught by a professional person, and they should be doing it religiously for at least 3 months. And it is after that period that they can say that the exercises have not helped one person as they would have liked it to be. But before that, it might not be appropriate to sign it off. And again, the same goes not only for the exercises, for the various medications which we use for urge incontinence. Again, they are all slow-acting medications, and we tell people very clearly that please don't expect miracles overnight. It is only a few months before you will start appreciating the benefits of it. So the more I understand that it is a frustrating wait for the patient, I'm afraid it is not a quick fix. It needs time, and it needs the medication or the exercises or the other therapies to take effect slowly and gently. So it needs a bit of perseverance and patience.
Okay, that's wonderful. Thank you for answering that. I have a question that's come through from a Sister Asifa from Luton. Is it true that every single woman who child bears is going to suffer from some type of incontinence in her life, regardless of whether she has a cesarean section or gives birth normally? That's a good question.
I would say that the answer is probably no. Not everyone will suffer any element of incontinence.
Okay.
Yes, a good proportion of them would do that. If
Okay.
they've had multiple childbirths, if they were big babies, and if they were any precipitating labor issues or prolonged labors, and if there was any other obstetric related complications or instrumentation, then the risk becomes far higher.
Okay. Okay.
But I would not generalize it to say that everyone will have an element of incontinence. That might probably not be very appropriate.
Okay, which basically means this is one of the things that we actually do in our 6-week postnatal check examinations, Mr. Ahmed. We always tick off that we have educated a new mother on pelvic floor exercises, indeed after every birth when she presents at the 6-week check. And I'm sure that it's very important, just speaking about this, and one thing that I've taken home from my own learning need is to actually emphasize on that, because you can have people who give birth multiple times and the experience is that they will suffer from some type of, whether it's mild or whether it's severe, incontinence in their life, especially if they have given birth multiple times as well. So I think a message for doctor colleagues in primary care is also to lay emphasis on those pelvic floor exercises, to actually start even if they don't have symptoms.
In all the urology setups and departments in every area of the country, people have now subspecialized into various areas of work. And like, for example, I specialize in stone work and upper tract kidney problems and prostate disease, etc.
Sure.
There are lots of colleagues who have got a subspecialty interest in incontinence, be it male or female, and they have got a wide spectrum of options available to treat and investigate and manage this population. So therefore, if you are having any sort of problems, please get yourself checked up, referred appropriately, so you can be seen by an incontinence specialist, a female and reconstruction urologist. And as I said, we have got these colleagues available everywhere in the country. So please feel free to contact us, and we are there to help you.
That's wonderful. Do you know, it's been such an educational show, Mr. Ahmed, just because of the fact that we have had so many people actually join us and who are engaging a lot of interest, and I can see them pop up on the Facebook page. It is wonderful to have these shows because there is a lot of stigma surrounding the thought process of going into hospital or being seen by a specialist for urinary tract symptoms, and sometimes if it's left too late, there is only so much that can be done. So the sooner these symptoms are seen to and investigated, the sooner recovery can be sought. Do you have a message today before we say goodbye to you, to our patients, please?
The simple message is, take your body and take your symptoms seriously. Even if they are not adding up, even if you're not clear what they mean, please seek help and please get yourself referred. And for my friends in the primary care, again, even if you think that it's a very simple thing and you don't think it really needs very much doing, if in doubt, always ask for help.
Well, thank you very, very much, Mr. Shabi Ahmed. It was an absolute pleasure to have you on. I always say that 1 hour is too less, but inshallah we will be having you again in the future.
Thank you very much. It was an absolute pleasure to be with us, and a big thank you for all your listeners from wherever they joined us. And if I can be of any service, if they need any feedbacks or if they have any queries, please feel free to get in touch with me. I'm sure colleagues in Salaam Radio will facilitate, and I'm more than happy to answer any of your queries and questions as they may be.
Thank you very much, Mr. Ahmed. We definitely will take you up on that. Assalamu alaikum.
Wa alaikum salam.
So that was Mr. Shabi Ahmed, who gave an absolutely fantastic show on urinary tract symptoms. We've reached the end again, and I've got to tell you about these family fun days that we're going to be having on Saturday, the 31st of March 2018. The time is 12 p.m. to 5 p.m. There will be food, bouncy castle, henna, clothes, raffle, and much more. It's being hosted by Salaam Radio and Penny Appeal at Gladstone Community Park Centre on Burgess Boulevard in Peterborough. And please contact Brother Qasim for stalls on 07722 55 884. And our next event will be for the Syria Emergency Fundraising for Ghouta on Human Appeal on Salaam Radio live on the 24th of March from 4 p.m. Continue to support us, my dear listeners. Once again, your very own Dr. Shabina Sivkiyum will be back with another show with a wonderful professional to try and educate and enhance our knowledge. Until then, from me, Assalamu alaikum and peace be upon you all.